Thank you very much, Tom, and thanks to all speakers. It was really fantastic, really, really fantastic. Now we are, as Tom said, we are currently at the questions and answer session. Sorry. The first question is: does country to country vary the medical equipment maintenance standard? If so, then how the traceability maintenance? What will be the standard for Bangladesh? Maybe Mohammed, you want to answer?
Yeah, sure. For this one, we are working with the Director General of Drug Administration. We have the Drug Control Committee, but in that committee, most of the professionals are doctors. So we have requested them to bring some biomedical engineers in that committee, especially in the Medical Device Technical Committee and subcommittees. And together with this, we have the National Electromedical Equipment Maintenance Workshop and Training Center. So very soon, this will be also reforming with the several hundred of biomedical engineers and biomedical technicians. And just recently, we have completed the medical device manufacturing guidelines following the ISO and IEC other regulations. And we already working with the other decision makers for the successive, especially the regular inspections and the QC of medical devices with a specific time interval in every government and private hospitals. We,
Okay, thank
the
you very much,
clinical engineers
Mohammed.
community, are working hard for this one. Thank you.
Okay, thank you very much. I would like to add here only thing that the traceability is able to be established through the calibration. So you have to do the calibration in accordance with ISO 17025 standard to establish the traceability. So that's the way how you can establish traceability.
Sure. For this one, we are buying several medical device testing equipment, including the gas analyzer.
Thank you.
Other
Anyone else? Does anyone else wants to give some kind of answer on this question?
I propose we move on with the limited time.
Okay, thank you, Tom. Then the second question, is it possible to share the IEC standard for medical metrology? Well, IEC are International Electrotechnical Committee standards, and they are mostly talking about the electrical safety and performance. They are not really talking about the medical metrology. And legally, if we are talking, all of those standards should be bought from the institution or from the person. So I will answer on this question, and I will also give the other questions to my colleague, to Tom Judd, to continue with those questions.
Yeah, a lot of those documents are available, as you said, and you outlined several of them, and people will get this presentation to be able to download it and find those and communicate with us. So that won't be an issue. So a third question was the steps considered in Bangladesh or anywhere to control sustainable coronavirus. And we all know the certain waves have already hit and more to follow. And you got two answers from us already, and following WHO guidelines and their ongoing guidance, which we put Adriana Velasquez monthly newsletters, or more frequent than monthly, on our website, and we also share all these webinars on these topics. And so those are good answers, and I think Dr. David's answer is also good. Perhaps we can move on to, particularly in the context of health leader communications. I love these final two questions from Rosanna and Roberto from Peru and Mexico. Mary, what do you think is the highest difficulty in decision making regarding COVID-19? What have you experienced in Peru? And this is Rosanna's question.
Well, in Peru as a country, it was very challenged, okay, because we didn't have like a sanitary politics very clear in all the cities in Peru. We don't have the resources, so we don't have an action plan for the continuity of the operation. But in AUNA, we did it very, very great, because we anticipate everything that was happening around the world. So we prepared buying the medical equipment, doing an action plan, preparing the people, buying all the elements that we could manage and confront this situation. But as a country, we are not good, as you know, Tom. some days ago, our president was vacated, so we don't have like a minister of health, we don't have a minister of economy and politics. So it's a Peruvian crisis right now in all the sectors.
The other panel members may want to answer that. I'll give an answer, but others may be thinking about it. One of our leadership qualities is adaptive decision making. In other words, we get to be at the table with the other stakeholders that are the decision makers together. So we're at the table because we've earned that position. But second, we have to adapt to changing circumstances. I mean, if I'm in a small group there, the stakeholders that are making decisions in your country or any of the countries, I would say, what's the latest information from WHO? Are we able, for example, in the context of COVID equipment, for example, respiratory equipment, do we have the oxygen systems that we need, and what are we doing about that? Are our patients, are we able to treat them at a lower level of acuity so that maybe the high flow oxygen or maybe the CPAP would work, and so maybe we don't need quite as many ventilators? We have to adapt to what we're finding. I mean, in my country, more people are getting because there's more there's more testing. They don't necessarily go together. Testing does let us know what's going on with people, but more people are getting COVID, but less are dying. So maybe we're catching them earlier. Maybe we're treating them better in the middle of that because of things we've learned over the last 6 months. And so this team has to be adaptive in its decision making. In my mind. Other panel members on that topic? If not, I know we've got about a minute left. I think Roberto, from the head of Senatec there in Mexico, has asked an outstanding question. And it was, if you were going to place clinical engineering or health technology at the best place in your Ministry of Health, where would you put it? I don't know if the panel has thoughts on that. Yadin, I don't know if you have thoughts on that. To me, it's partly, is it in the financial side? Is it in the clinical side? Or is it maybe in the operations side? In a particular country, once again, if I was at the table with these decision makers, I would look at which one of those departments. I mean, I realize we don't have this luxury of just choosing where we get to be, but I would think about which one of those areas has the greatest strength. I know Senatec started, they were part of the clinical side with clinical quality, and when Senatec started, the director of Senatec, Adriana, was number 3 in the Ministry of Health, and number 2 was the guy in charge of the physician in charge of quality. And so that drove Senatec's early success and how it was structured. So, and then every week I understand that department of the Ministry of Health worked and did many health technology assessments, and then changed how they delivered healthcare in Mexico, like almost in real time. They did a quick study and then they tried to implement solutions. So where can you be a part of a team that's actually making a difference and doing things expeditiously is my answer, but maybe there's other answers from the panel.
If I can jump in, I was in Monterrey in Mexico when I was asked several years ago where the biomedical engineering program should be housed. Should it be in the medical school or in the engineering school? And my response was in the medical school, because, like Roberto questioned, you want to be in a community where your goals are the same as the rest of the members. So your dream will become true because of the community pushing the same direction. If you are in the admin finance, your dream and your goals might be secondary to everybody else that is fighting for resources, and therefore your achievement would be slowed down for lack of support. So I definitely think that the appropriate way to go is to have the clinical engineering program within the medical / operation and find an infrastructure, just as I was thinking about the biomedical engineering education program should be in the medical school and not in the engineering school.
And Yadin, I think you and I are saying the same thing. So I agree. Go ahead, Mary.
Tom, I think, according to my experience, it will be allocated to the general management or the financial side, because the more impact, the more influence that we have in the decision-making table, it will be close to the chief of financial operator officer, and also to the CEO.
So once again, you're sensing what's true in your country, you know, and that may be where the greatest strength is. And so you have to be wise as you are to look for that. So very good. I think we need to bring it to a close, unfortunately, and we turn to Almir for closing comments.
Okay, thank you very much, Thomas, once again. And first of all, I would like really to thank you all. Thanks to Mary, Melvin, Adrian, Mohammed, Minister, also Ankita, and to all of you who took a very active part in this webinar. Thank you, Tom, for such a great job. Thanks to all other contributors and our members of Clinical Engineering Division. And until the next our webinar, see you, and I wish you to stay healthy and stay positive.
And see you in 1 month on December 9th. Thanks a lot, and bye for now.
Thank you. Bye-bye.
Bye, thank you.